Sickle cell disease is a genetic disorder that's passed from parents to their children. Their red blood cells change shape. They no longer are able to carry oxygen effectively, and so the organs of the body that are supplied by those red blood cells don't get enough oxygen. This causes pain. Severe crises can result in bone marrow failure, strokes, heart attacks, and on rare occasions, unfortunately, death.
Well, sickle cell has a lot of limits for me. It's limited me from finishing school as fast as I would like to. I have a lot of pain crises where I'm stuck at home or at the ER.
Sickle cell pain is very intense, of a nature that requires high-potency opioid analgesics.
I do have difficulties getting my pain dosage corrected in the ER, and I come to the clinic for that main reason. It's so much easier for me.
Sickle cell care at South Miami Hospital is the preeminent sickle cell service provider in Miami-Dade. We have the primary care clinic, we have our referral network, we have the infusion center, which allows us to provide disease-modifying medications to decrease the number and severity of crises. There is no treatment in the United States that Baptist Health can't provide for a patient with sickle cell disease.
The nurses and the doctors, I feel like they actually do listen. They don't treat me like I'm just a patient. Like, they treat me like they're family members. Like, they want you to have a better life. It's not just here to put a Band-Aid on you, which, they want a solution.
We don't use protocols. Each patient develops a unique, customized care plan, as opposed to everybody gets the same level of care.
Being in pain, it's overwhelming. Dealing with that 24/7 can get to you. Chaplain Steve comes down to talk to me every once in a while when I'm feeling a little overwhelmed with life. And then he also plays the guitar and sings music. So he's kind of like my music therapist at the same time.
I see you riding around town with a girl I love, and I'm not forgetting you.
Well, lately for me, I haven't been going to the hospital as much since I've started coming to the clinic. It's helped me stay out of the ER a lot more. I am a part of a nonprofit organization called ASAP, Advanced Sickle Cell Advocacy Project. It's so awesome to see so many patients, from little kids to adults, feeling good and enjoying themselves. We are normal people. We do regular things. We can live a normal life as much as we can when we're not in pain.
We are making a difference in their lives. Patients that were having frequent hospitalizations have gone without any. Patients who have frequent crises are noticing a decrease in the occurrence of those crises. And patients who are in crisis are receiving the pain control and disease modification they need to come out of crisis so that the disease is not negatively impacting their life.
Good evening. I'm Dr. Yvonne Johnson, Vice President and Chief Medical Officer here at South Miami Hospital Baptist Health. We want to welcome everyone to this special edition of Baptist Health NAACP Health Talk. We're coming to you today from the campus of South Miami Hospital, home of sickle cell at Baptist Health. We just saw Anais's story in the video, and I think that it puts sickle cell disease truly in perspective. Here are some recent data about the disease from the CDC. Sickle cell affects about 100,000 people in the United States, and more than 90% of those people are Black or African Americans. The estimated life expectancy of those with sickle cell disease is 20 years shorter than the average American. The data show that many people with sickle cell disease do not receive the recommended healthcare screenings, treatments, or appropriate pain management. Joining us for today's forum is Dr. Neil Moransky, a Baptist Health palliative medicine specialist who inspired and operates the sickle cell care at Baptist Health South Miami Hospital. We are also pleased to welcome Josiah Frierson, a sickle cell patient at the clinic. And Mr. Frierson, thank you for sharing your experiences with us here today. We just saw that amazing story. Dr. Moransky, please give us a brief overview of what is sickle cell disease and tell us how care at the clinic differs from that in other settings where sickle cell patients have traditionally received care.
Thank you. So sickle cell disease is a genetic disorder that's passed on from parents to their children. And it affects the ability of a person to carry blood in their red blood cells. When a person undergoes something called oxidative stress, or they have infections, they overexert, what can happen is the red blood cells pop into a new shape that doesn't carry oxygen and gets caught in blood vessels. Our bodies don't do well when there isn't good blood supply, and then you have consequences from that ranging from injury to each organ, typically associated with a great deal of pain. And this is a recurrent process that happens from birth going forward, usually presenting initially after about 6 months of life until the end of life. And so it impacts many, many areas of a person's life because it never goes away. It's a condition that is lifelong. What makes the sickle cell care services at South Miami different than what we commonly see is the depth and breadth of the resources and the commitment. So we put patients, the people who have sickle cell disease, at the center of everything we do. And that drives us to do things that are helpful and useful, to include all the preventive care, the screening, the disease state management, the symptom management that occurs during a crisis, and interventions that range from support to attempt at cure. We're using all resources that are available in the United States, and because we're a rather large organization with a great deal of depth and reach, there is no specialty that we can't provide for a patient with sickle cell disease as a consequence of that disease as it injures the body or progresses. And so customized care, nobody is using a protocol. Each person gets their plan because they're at the center of the care. It's different than anybody else's plan, and it's adjusted as that patient needs it to be adjusted so that they can live the life they want to, with the impact of sickle cell disease being minimized to the greatest potential that can with the technology and the science we have today, with a continual search for the science to improve tomorrow.
Mr. Frierson, tell us about your journey with sickle cell disease. When were you diagnosed, and what are some of the symptoms that you've experienced, and how has it impacted your life?
Yes. Well, I was actually diagnosed at 1.5 years. My mother said that I would cry and I would have a different type of cry, that she didn't know what exactly was going on. She took me to my pediatric doctor and when he went there, my blood was actually low. They didn't know what was going on. The doctor sent me over, it's not there anymore, it used to be a sickle cell trailer where they tested me, and I came back positive for sickle cell disease SC. After testing me, pretty much I had to grow up with this. From a child, my mother was given pain medication, literally from an infant stage, that when she heard that distinctive cry to give to me, to be able to help soothe with the pain, because I was an infant, so I couldn't tell what was going on with me. So with that being said, growing up as a child, I wasn't able to do the things that everyone was able to do. I wasn't able to go and play organized sports like my brothers and sisters were able to do. I was fortunate enough in high school to be able to do that, but it was pretty hard. But moving forward, I never let it get me down. It used to, as a child, I used to, say, why did it have to be me? Why do I have to be different? But when you had a father like mine that wasn't going to let anything get you down, you're better than this. You're going to push forward. You're going to be a leader. And literally, I kept going forward, kept moving in, played organized baseball in high school and did pretty good at it. Got offered a few scholarships. But baseball wasn't what my passion. I always wanted to help people. So went to school for firefighter paramedic. Yes, a sickle cell patient went for firefighter paramedic. And because to me, I wasn't that sickly, and I was like, I'm going to do this. But eventually, sickle cell caught up with me. And when it caught up with me, I was able to complete one part of it. I was able to do the EMT paramedic part, but the firefighter part I was not able to do. And it affected me because I went from working all the time, working in the hospital, to literally now I have to do things differently. I have to get on disability. But even in this disability, God still had a better plan for me. And before I know it, when I eventually said, okay, I've tried everything. I was in the hospital every month going through just being mistreated, going to sickle cell clinics, not getting the proper access that I need. And I went from that literally to just saying, okay, God, I want to live for you. And I became a pastor. I am senior pastor at my church, Razor Sharp Ministries down in Miami. And I'm now a senior pastor, and now I advocate with a group called ASAP, Advancing Sickle Cell Advocacy Project, where we go out, we're trying to get laws passed, we're going to functions like these, and whatever we can do to impact sickle cell warriors, to help sickle cell warriors, to bring awareness to sickle cell warriors. And yes, it was initially tough for me. It was, oh my God, but just the life I live now, even through the sickle cell, being able to help people, maybe not on the ambulance or in the hospital, but as a pastor, help people in a different way, help other sickle cell warriors.
I can absolutely understand how impactful that can be. You mentioned something about being mistreated in the hospitals and in your care settings before. What did you mean by that?
If you talk to pretty much any sickle cell warrior, they would all pretty much have the same story. The story about being mistreated, the story about telling the doctor that I'm in pain and the medication you're giving me is not helping, and then being looked at and saying that this should be working for you. Literally, every student I meet, I tell them to not listen to the things that are being said. Even working in the hospital, I was told things before I became an advocate. So yes, if I needed more medicine, I would be told that should work for you. Again, like I said, at a year and a half, my mother was giving pain medication for me to give. So I have a higher tolerance, but tolerance is not the same as addiction. And that's what the world has to realize, that the healthcare field has to realize that. So when I needed more medication, sometimes they will even decrease the medication. And you would literally be sat there to suffer because they refuse to help you.
That's an important point, that tolerance is not addiction. Dr. Moransky, let's talk about the Baptist Health Sickle Cell Care Clinic here at South Miami Hospital. How is it positively impacting patient outcomes? And can you speak a little bit about how it's addressing some of the concerns that Mr. Frierson raised?
Yeah, so sickle cell disease has a clinical presentation, in other words, a patient's experience, and it has a medical presentation, in other words, what's happening inside the body. So you can have continued ongoing injury without having significant increases in pain. And so you can't ignore one or the other. So what the program is doing is, one, addressing consequences and complications of sickle cell disease, kidney disease, renal disease, neurological injuries, strokes, bone injury and bone infarct. Basically, pick an organ system. If it gets blood supply and you have sickle cell disease, that organ can be impacted negatively. Additionally, the pain crises can range from mild, I have some mild pain, to some of the worst pain that can occur on the planet. So when people are having a heart attack, they say they have a crushing pain in their chest. That is an ischemic event in your heart. Now take that pain and stick it anywhere else. That's a sickle cell crisis. Or stick it in a few places. So it's an intense pain. The difference is we usually or frequently will have to use opioids as part of that pain medication regimen. So you need people that are capable, competent, and comfortable, well-trained and compassionate, and have a good sense of clinical judgment. Because if I treat you to my level of comfort as a provider, that not commonly associates with the patient's level of comfort. So you need to have an understanding of if it's safe to give more, if it's safe, and what is the dose that works for this patient during this crisis. When we said we put the patient at the center of care and each person gets their individualized program, well, what works for him may not be what doctors in the hospital are comfortable giving. But if you have doctors that are well trained in using opioids and other complicated symptom management medications, they can reach out to where the patient needs to be and give them what they need to improve their pain. If pain is happening acutely, that is something that's happening in the hospital, typically. But you don't have to go to the hospital for pain control. Right now, you have to go to the emergency room to get IV pain medicine because the pills don't go high enough. And so all the pain is fluctuating. So the pills you have are good for a month's plan, but this is a crisis right now. We have a storm coming in. We're having a change in barometric pressure. It's commonly associated with increased pain. And so what's going to happen is, right now, in most other areas, people go to the emergency room, meet a doctor they don't know, and ask them to please give me a dose that normally would not be tolerated by anybody else because I'm asking. And that's a scary position for doctors to be in. If you come to a home, we know you, we've seen you, we've adjusted your meds on an ongoing basis. We don't have to go through that whole acquaintance, please believe me. We can respect the patient can respect their healthcare team. We can give them what works, is safe and effective, and adjust it as it goes forward. The one other part is the daily pain. So as you have injury, a common occurrence in sickle cell disease is something called avascular necrosis. So you age really rapidly in your shoulders and your hips. And so a person who's 20 years old could essentially, effectively, have the hips of an 80-year-old. It hurts. Just ask any 80-year-old when they get up. Well, this is a daily pain. Well, yeah, but this is a daily pain. They can have injury to nerves and other things that have occurred and aren't going away. It has nothing to do with an acute crisis. It has to do with, this is what I live with now going forward. And so giving effective medications for that is important. There is one guiding principle that as a patient or as a family member of a patient, you should always require, demand, insist upon, and that is that the intervention should improve your symptoms, your quality of your life, and improve your level of function. This disease interferes with life. And if you can manage the symptoms, then you can do things like stay in school, graduate, get married, raise kids. All of the components that everybody wishes to have in a normal life. We need to, as healthcare providers, be brave and educated enough and capable enough to go into the breach to cover the need so that people can live the life they want to improve their quality of life and their level of function. That's what this program does. That's why this program exists. That's how we define success. And that's when we know if we're falling short, that's where we focus to improve.
Well, I absolutely can affirm that, when you come to an emergency room as an emergency medicine doctor and people don't know you, there is a lot of reluctance to give the doses of narcotic medicine that are required to actually give you relief. Dr. Moransky, you mentioned that you create these individualized plans, care plans. Are those available in the emergency departments or in the primary care physician offices for other caregivers to follow that plan?
Yes, we want to remember our goal, improve quality of life and level of function. So we opened all the doors. What that means is our notes are accessible in any one of our hospitals. Additionally, if you have a hematologist that you are familiar with, comfortable with, they're not part of our program, and the patient's in agreement, we co-manage. They're aware of everything we do. We call and update and discuss cases with the hematologist if they're not part of Baptist. But that way, if a person is admitted, then the ED physician go, oh, he goes to the Sickle Cell Day Hospital, and he normally gets this dose. This is how much he got in 6 hours. And then when he's saying the same thing as what is in the note and signed off on and certified, it makes it easier for that doctor to say, okay, this makes sense. I'm going to give what he's asking for, she's asking for. They've proven they can do it before.
Yeah, I can see how that would be very helpful for a caregiver who's not necessarily familiar. Mr. Frierson, we know you're very active in the community, advocating for increasing awareness and improving access to sickle cell disease care, especially in marginalized communities. Tell us a little bit about that and what advice you would give to those who may need screening or care.
Okay, yes, of course. As I said earlier, I am part of a group called ASAP, Advancing Sickle Cell Advocacy Project. We literally have done stuff from putting on faith brunches with partnership with the city of Miami Gardens, where we put on faith brunches, do different things with them that we do. We literally have an ASAP day with the city of Miami Gardens, where they have recognized us with our own day. I want to say Dade County too, but I don't want to say the wrong thing.
If not now, then we'll
Not
get
now.
there.
We'll get there. Don't worry about it. Maybe I'm looking. Maybe I'm speaking it into existence.
There you go.
But what we do is we put on things like this. We have a COPE program for our children, helping children and parents be able to cope and deal with how to manage this condition. How to deal with this condition. I remember things that I went through as a child, things that my parents went through. And it can be stressful not only for the warrior, the sickle cell warrior, but also for the parents, also for the caregivers. So this is programs where different parents can come together, different things, and be able to help each other, learn from each other. We do monthly sickle cell support groups as well. Virtual now, I believe we're going to go back to in person as well. But we do virtual things as well that we can be able to talk to each other and I can learn from each other. And literally just this Saturday, I was able to ask a question to someone about something that I was a little concerned with, talking about the avascular necrosis like Dr. Moransky talked about. So these things are very important. They're good for the community. And one thing I do know is, as Dr. Moransky talked about, having physicians that are educated and that are comfortable. Well, when it comes down to testing, that is something that is very important as well. I have been in a situation where I've had to help people because the physician didn't know the actual name of the proper test, and they may have ordered the wrong test, and they're trying to figure out how, what can they do. Something as simple as a hemoglobin electrophoresis. So stuff like this is very important. I believe in the state of Florida, Dr. Moransky, you can tell me if I'm wrong, that every African American is tested, if I'm not mistaken, for sickle cell screening. But ask your doctor, ask your hematologist, know these things because it's very important. This is a genetic disease. So you don't want to have the trait, maybe mate with someone with the trait, and now your child has sickle cell. Yes, we may deal with it, but let's try to prevent this as much as possible.
Those are really important issues that you bring up, so thank you. And Mr. Frierson, Dr. Moransky, thank you both for your insights. But before we switch over to part 2 of our program, I think Dr. St. John has some questions from the audience.
Thank you, Dr. Johnson. Thank you, Dr. Moransky. Thank you, Pastor Frierson. Really impactful and moving to hear your experience and the impact on your life. So we really appreciate you coming out. I'm going to pause and see if we have any questions from the audience. I see one from our chaplain, and then we may have some opportunity for the online audience to ask questions.
Yeah, I just have a general question about research, about funding for research. Where does it kind of rank sickle cell versus any other disease? And what might be some of the barriers to funding and research?
Before you answer that, Dr. Moransky, I think that's a great question. I wanted to add on to that. What is the impact on that question, do you think, of this being predominantly a black disease?
So, a couple of things. So, in the state of Florida, all newborns are screened for sickle cell, and that's a milestone that's important. We should get that in every state. Sickle cell disease is seen as a black disease. Sickle cell disease is actually a malaria disease. It's based on a distribution of where, over time, malaria has been prevalent. So you can find sickle cell in the Mediterranean, in North Africa, in Italy, the Caribbean, the continent of Africa, and then the African American community or black community in the United States, and South America and the Hispanic community. Funding has been scarce and scant. There has been significantly more funding for other genetic disorders typically found in Caucasians. I can say that there is some significant light on the horizon. So this is one of the things I'm just interested in. So I keep an eye out on research and drugs in the pipeline and disease-modifying interventions that will be applicable to many diseases are being applied to sickle cell disease. And so there are 8 different studies that I'm aware of right now about different modalities and interventions. So the future looks a lot better than the past.
Thank you so much. I think we have time for one more question. Dr. Hernandez, we'll get to you maybe in the next segment.
Thank you. Why is it important to understand the implications of the sickle cell trait, and how can an individual get tested?
Thank you. That's a great question about sickle cell trait and what should you do if you have it.
So sickle cell trait means you carry half of the genetic material to pass it on. So if you carry sickle cell trait, then it would make sense for you to know, as Josiah was saying, if you plan on having children, there is a value to having genetic counseling with your partner to identify if you have an increased risk of passing the trait or the disease on to your offspring. And additionally to that, you need to make those decisions for yourself and for your family. Just because you carry the trait doesn't mean you shouldn't have children, but you should go in with your eyes open. And the way you get tested is it's a simple, non-invasive blood test. The same way you go and get a regular cholesterol screen, you can collect that blood and we can see if you have any genetic components for sickle cell disease, sickle cell trait.
Thank you. And Dr. Moransky, last question, if you can quickly answer this one. It's from the online audience. What first drew you to focus on sickle cell disease? I think it's a brilliant question. I'm interested.
Oh,
to
and
hear.
I can answer that in 10 seconds?
Good.
Okay, so sickle cell disease is one of the most complicated symptom management diseases in the world. I manage a lot of people with a lot of bad things as part of my palliative intervention. And sickle cell disease management is more complicated than most cancer disease management from a symptom standpoint. Additionally, the relationships with the patients are deeply meaningful. We develop lifelong relationships. And it is, while I'm with the patient during some really hard times, my job is to make their life as good as possible and open doors. As a doctor, I don't think you can ask for much more.
Thank you so much.
Well,
We're going to.
No, I was going to say, I can certainly see why sickle cell care at South Miami Hospital is so outstanding and so impactful, and have outstanding patients like Mr. Frierson and care given by Dr. Moransky. So thank you.
Thank you.
Thank you again, Dr. Johnson, Dr. Moransky, Pastor Frierson. We're going to take a brief moment for the online audience. We're going to leave you with some information on sickle cell care here at South Miami. The in-person audience, we're going to do a little set change, and we'll be back in 1 to 2 minutes.
Thank you so much.
Hello again. I'm Dr. Marcus St. John, and I'll be taking us through the second part of our conversation on sickle cell disease. Part of what we've heard today is the need for education and screenings. Joining us now to talk about resources for the community are Harold Ford, President of the South Dade branch of the NAACP, and Dr. Mildred Berry, President of the Board of the Sickle Cell Miami Foundation. Thank you to both of you for joining us this evening.
Thank you.
I want to start with you, Mr. Ford. Baptist Health has partnered with the NAACP to produce podcasts focused on healthcare topics affecting the Black community. How do we leverage these partnerships to potentially expand the clinic's services that we've heard about and enhance community outreach for long-term success?
Well, partnerships with the NAACP and other organizations will definitely lend itself to helping getting the message out, first of all, of the importance of dealing with issues such as sickle cell and its impact on the community and those families. In addition to that, we also lend ourselves and our reputation and credibility to helping have people have confidence in what this clinic is doing to help those that are suffering from sickle cell and that live with it daily. So in addition to that, we would also promote the expansion of our connections or our agreements with other entities, i.e. like Miami-Dade County Public Schools, like Miami-Dade County, like some of the businesses and organizations within the community, so that again, we can not only get the message out, but help also bring resources to the clinic as well.
What are you mentioned Miami-Dade Public Schools. Are there any particular resources in the school system to advocate or help students with sickle cell?
Yes, we've had some of our board members actually do presentations with the school district to those counselors so that they can understand the impact of sickle cell patients in the classroom. For example, in physical education classrooms, If kids get overexerted, they may have an episode or they may develop certain symptoms which could prevent them from completing those particular tasks that they were asked in those areas where they were overheated or overexerted. So we wanted to inform those counselors as well as some of those education professionals the impact of sickle cell and what it could have on that child's educational progress.
Right. And last question on this sort of topic, and maybe Dr. Berry, I know you're an educator. Are there specific accommodations that schools or other institutions can leverage?
There are accommodations that are made for students who have what I would refer to as chronic disease, because
Right.
sickle cell is a chronic disease.
Of course.
And as a teacher educator, part of what I do is inform the new educators that they will have children in their class,
Yeah.
that they must be aware of their condition as well as what they can do to help. Because we started out as, and we still are, a support group. And as was said earlier, the funding is limited. We depend primarily on donations to help people with sickle cell. And most of our work is with the University of Miami, because we originally was an advisory group
I see.
for a grant that U of M had earlier.
Got it.
And if I can add, Dr. Johnson.
Of course.
I mean, Dr. St. John. What also, as an educator with K-12 classrooms, we encourage parents to also seek to have a 504 plan, implemented on behalf of the students so they can get those accommodations that are needed to help them in the classroom. And depending on the severity of the circumstance, if they need to have an IEP or an individual educational plan implemented,
I think
those tools that are needed.
Excellent tools and resources that many parents may not know about. So I think it's important, the work that you all do, that families know that they have certain legal rights to accommodations when they need them. Dr. Berry, given that sickle cell disease predominantly affects African American and Black communities, how is the Sickle Cell Foundation tailoring its outreach and care strategies to meet the unique needs of these populations?
Primarily, we work with University of Miami, Dr. Harrington and Dr. Alvarez. One is a pediatric physician, the other works with the adult sickle cell population. And what we do via a grant, we have a clinical health worker who also assists people with sickle cell, who also speaks Haitian Creole, which makes a difference because she speaks the language of many of the people who are impacted with sickle cell. It's challenging, but we keep going. And primarily it's challenging because most of the groups that give you funds, the funds are for education. But too often, we have clients who have food challenges, who have transportation challenges, as well as financial challenges. And so we try to allocate the funding that we receive to help as many people as we can.
Yeah, I think you just identified one of the things that really we have started to finally learn in medicine, that it is more than just the disease, but it is all the other elements that get a patient to being in a doctor's office or a nurse practitioner's clinic. And many of those things, we call health-related social needs, are things that you're talking about and addressing. Mr. Ford, I know there's an event coming up, or hopefully coming up this weekend in conjunction with the Sickle Cell Foundation. Can you tell the audience a little bit about it?
Yes, this Saturday, the 28th, from 10 a.m. to 4 p.m., we're going to be holding our annual Sickle Cell Disease Association Awareness Family and Friends Picnic. It's going to be on Arcola Lakes Park. The address is 1301 Northwest 83rd Street in Liberty City. So we invite any and everybody to come out. If you haven't seen the information, we do have a QR code. We want you to RSVP. You can also go to the website, scdaamiami.org, and RSVP there. So we definitely want to see everybody, weather permitting. We pray for those also that are going to be impacted by the upcoming storm.
We appreciate that. And Mila, if we could put that information in the chat so people can know where that event is, what the details are, and we would love to support it if possible. Final question to both of you. What other resources, so we've talked certainly here about the clinic, would you recommend to someone that needs to find out more about sickle cell disease?
Well, one of the things I recommend, and unfortunately, all of us have heard this term, Google it. Because there is a wealth of information about sickle cell there. Plus, you can also go to our website, and you can also go to SCDAA, the national group,
Right.
and they have resources available as well.
Got it. Well, I love that. I'm going to take that with me forever, I think, Dr. Berry. So count me as one of your students. I'm going to hand it over to my colleague, Dr. Johnson, who has moved to the audience, and she's going to facilitate some questions.
So I know we put Dr. Hernandez on hold from the last session, so I'm going to let her ask her question.
Thank you, Dr. Johnson. First, I want to salute everyone for the wonderful work you're doing. My question was for Dr. Moransky, who's sitting behind me, so I'll pass the microphone. In addition to the concerns around prescribing opioids, can you speak to what role implicit bias may be playing in the undertreatment? And also, how can we ensure equitable access to emerging therapies?
Well, that's a simple question. Okay, so two answers. First, on implicit bias or unconscious bias. If you are close to the concept, that's a problem. So identifying and being open to the fact that you have, because you're a human being that has a pulse, an unconscious bias or potential bias, then you are open to hearing what other people can say. Better. You're open to what other people are saying, so that you have an easier time hearing criticism or feedback. And if you hear that as you continually improving who you are as a person, then that doesn't pose a challenge. As far as the question was treatments that are coming forward and access to those treatments. So for a long time, the only medication we had was hydroxyurea. Dr. Alvarez at the University of Miami was doing some of that research. And so hydroxyurea increases lifespan for patients. The problem is it's not easily tolerated for some patients. So then for a long time, the only other intervention we had was bone marrow transplant. Bone marrow transplant has about a 19% success rate. And you have to have a match. And so it gets really complicated. And that was it. And it was complicated because you would have to take medications for immunosuppression to be able to tolerate the graft. We then developed new technologies, some very exciting technologies on basically three fronts. One, to stabilize red blood cells, and that is cutting hospitalizations and occurrence of sickle cell crisis in half. It's covered by most insurances in the United States. We don't have an access problem. We have to go through authorization, but we don't have an access problem. The other modality that's available is to make the red blood cell less likely to stick to the vessel lining. And so that also covered by most insurances. It's some hoop jumping, but you know what? It's achievable, and it is something that is making a difference. About 50% of the occurrence of sickle cell crises are addressed with that. Then finally, we have gene technology. So New England Journal of Medicine last year published an article on research for a CRISPR gene. This allows us to take a person's own red blood cells and own bone marrow, well, actually the bone marrow itself, and modify it. So it gives you the genetic effect of hydroxyurea without any of the side effects. Right now, 25% success rate, which is higher than bone marrow transplant, and the course for immunosuppression is not nearly as challenging, and the duration is not lifelong. This is a exponential change because this is something that's being applied to sickle cell disease, but this technology will allow us to apply it to almost any other genetic disorder. And so the challenge is access. This treatment costs between $2.2 and $3 million and is very difficult to get access to. As we have new technologies and other modalities coming online, that should help. And also the recognition that this is a disease state that there should be criteria to qualify for this process, will open access because it is functionally, as the data shows to this point in time, at the beginning of this treatment. In other words, we should expect this cure rate to improve or functional cure rate to improve, is a cure for the disease. And that means everything. Imagine being born with type 1 diabetes and you go into the hospital for a few days and you come out, you no longer have type 1 diabetes. It's equivalent. It's a cure. It doesn't stop the passing of the genetic material on to your children, but for your life, you don't have sickle cell anymore.
Sounds like we have a lot to hope for and a lot of good reason to hope. I see another question over here. Jennifer?
Thank you. Sickle cell affects mental health greatly. So are there any plans to incorporate any mental health professionals as part of the clinic, any therapists or psychologists?
Okay, I guess I'm a little bit of a mic hog. Okay, so the answer is yes. That is actually one of our goals and initiatives under foundation funding. In addition to accessing for referrals. So we're in talks right now with a group of psychologists to see whether or not we can access the service for our patients. It is critical. There's good data to show it makes a difference for our patients. And anybody that can't see that having a life-limiting condition that impacts you on a daily basis couldn't benefit from coping techniques, support, and ways to think about and expressions of frustration and hopes and dreams is not awake. So multi-pronged, one, covered by insurance, two, accessing through our foundation money as we are able to. This is a service is definitely high on our priority list.
Thank you. Do we have any other questions online? I know there were some for this audience. Okay, then I'm going to turn this back over to you, Dr. St. John.
Thank you, Dr. Johnson. Thank you for those questions. So as we start to wrap up, I want to thank all of our guests for joining us, Mr. Ford, Dr. Berry, Pastor Frierson. I want to thank our live and virtual audiences for joining us here tonight and taking some time out to hear about this important disease and the ways that the Sickle Cell Clinic here at South Miami is really impacting things and making a positive change. I want to thank the behind-the-scenes folks with the physicians and Black BRG who made this possible. I want to highlight Karen Vassell and Jovanda Crashfield, who really did a lot of behind-the-scenes work, Emilio, and the whole team. So this didn't plan itself, so thank you guys. I want you to please follow Baptist Health across all our platforms to be better informed about sickle cell disease and other conditions. We'll be posting this forum on your YouTube and podcast channels where we'll be offering many of the resources that we've talked about today. Thank you again for joining.